Mr. the Chairman, ladies and gentlemen, I would like to thank Dr. Sultan and the scientific committee for their kind invitation to share with you our experience in sleeve gastrectomy done under block anesthesia. We know that morbid obesity is a major health problem affecting 20 to 30% of the general population worldwide, with 10% of these having morbid obesity. We know that 10 to 15% of these morbidly obese patients are above the age of 50 and have multiple comorbidities, so they are not referred to us because of these comorbidities labeled as high risk for surgery. We know also that stress response from general anesthesia and tracheal intubation is dangerous in patients, and especially in patients with morbid obesity having more cardiovascular risk, and this has been proven in a lot of studies. And this is where we started to think, why not to start to do a sort of block anesthesia rather than going to general anesthesia. And in our department of surgery at Maqasid Hospital in Beirut, we have an excellent anesthetist, Professor Zuhair Naja, who started to do the block anesthesia in 1995 on small surgeries like hernias, hydroceles, and then we progress bit by bit till we reached colectomies and small bowel resections. And it was in the year 2000 when we did our first laparoscopic cholecystectomy under block anesthesia. I will show you the technique. Can I run the video, please? So you can see here, this is the buttock of the patient. And this is the head, this is the vertebral column, and he did a sort of paravertebral block. You can see here the muscles contracting, localization done by a neurostimulator where he gave electrical impulse and he saw the contraction of the muscle, and then he injected the long-term anesthetic, and we will have our block anesthesia. So we started in 2010 to do sleeve gastrectomy under block anesthesia. The usual technique of sleeve, 5 centimeters from the pylorus. We use 2 green cartridges at the pyloric antrum and 4 to 5 blue cartridges cutting the stomach. We cut it over a 36 French tube, start liquid diet on the night of surgery, no drains, no upper GI series, and patients were discharged on day 1. Can I run the video, please? And this is our first sleeve gastrectomy done under block anesthesia. Really, it was challenging, and there is a lot of technical difficulties that we encountered, and we modified till we reach really a comfortable anesthesia. We have problems while insufflating the abdomen. We should do the insufflation very slowly because the stretching of the peritoneum will cause a lot of pain. So we cannot reach high pressure immediately. We should go to 12 millimeter, not more than 12. And if patient is comfortable, we can go for 15 millimeters. So really, it was not that easy. And also, you can see here, the space is not very good. And when we reach the GE junction, the problem that we have also is severe left shoulder pain with a lot of nausea and vomiting. And also we modified our technique by giving Zofran on the induction of anesthesia and avoid manipulation as much as we can at the GE junction. A third challenge, which is the insertion of the oral tube. It is difficult to put it in the awake patient, so we were obliged to put a sort of sedation while putting the oral tube. Anyway, I think we reached at the end a good surgery, and with patients who are, you can see here the space and the oral tube. It is not a good space, and the oral tube inside. Run the next video, please. And this is one of the last patients that we did like a year ago. He is really comfortable. We can talk to the patient during the operation. You can have the sound, probably. So during this surgery, we were able to discuss with the patient whether he feels any pain. We can have the voice? No? Nobody? Okay. So as we can see, the patient is awake. We are asking him if he's feeling any pain, and actually he is feeling nothing.
سيد عدنان كيفك؟
الحمد لله.
الحمد لله. طلع فينا شوف شوي. فكرة.
هي ما تخيل.
أنا بعضنا شوي صغير مخبري. شو سيد عدنان؟
Extraction of the sleeve.
Okay. نعم. خلصنا 5 دقايق. ضايق من شيء مسوي من شيء سيد عدنان؟
And you can see that at the end of the procedure, the patient is really fully relaxed. He don't have the effects of GA like nausea, vomiting. He is really fully relaxed after the surgery.
طلع فيه شوي نعم. كنت عينين سيد عدنان؟
شيخ كيف الصحة؟
والله الحمد لله. الله يعطيكم العافية.
كيف كان مسار العملية؟ إن شاء الله الحمد لله خلصناها، أخذت معنا ساعة وربع الحمد لله وماش موضع.
ما شاء الله.
الحمد لله مسهل الأمور.
Okay, so we did like 20 patients, 12 females and 8 males. The average time was 60 to 120 minutes. Hospital stay was 1 to 2 days. We don't have any death, any leak, any bleeding, or conversion to general anesthesia. We have in one patient to stop the procedure because of severe buttock pain. And we did the procedure after 2 days. We give block for the buttock. He have a body mass index of 60. We have follow-up of an average of 18 months. The excess weight loss is 56%. Resolution of comorbidities, 10% for 15 of diabetics. We have 10 resolution, which is 75%. For hypertension, 50%. For sleep apnea, 90%. Which match the general anesthesia groups. Now just a few slides why I think that block anesthesia may play a role in the development of bariatric surgery. First, I would like to show you some data about the bariatric surgeries done worldwide. In Canada, for example, they have 1.5 million candidates. They are doing only 1,800 patients per year with an operation rate of 0.1%. And the US, with the highest ratio of doing bariatric surgery, they are doing 200,000 per year with a percentage of 1% only. And Germany, the incidence is 0.4%, and Lebanon also we are 0.4%. So I think if we look very carefully in this slide, we know that all of us as bariatric surgeons, we are working on this 1%. And we are leaving the 99% of the patients that they are really candidate for surgery, and we cannot reach them, tackle them, aware them about the procedure. And this is why I think the future for us as young bariatric surgeons is to emphasize the issue of awareness for the population. We have most of the morbidly obese patients don't know about the procedure, don't know about the safety. We should work on the coverage of the procedure. And this is where block anesthesia, I think, play a role in the last 2 items, which is making bariatric surgery simpler and safer and to market the procedure. Because by talking to the... Yes. Okay, I will go to the conclusion.
Half a minute.
Okay, conclusion. So by emphasizing the issue that we can do a surgery in a safe way and even under block anesthesia. So block anesthesia may be a feasible and safe type of anesthesia in bariatric patients. However, it did not replace the general anesthesia, of course. It may play a role in making bariatric surgery more accepted in the community, patients and doctors, and hence increasing the bariatric surgery load. Excess weight loss, resolution of comorbidities matched the general anesthesia data published in the literature. However, in our study, we don't have a long-term data. We don't have a big number of patients. So the future is to study more, probably to have a prospective randomized trial comparing sleeve gastrectomy done under a block versus general anesthesia. And we'll start in our department to do an outpatient sleeve gastrectomy. Thank you very much for your attention.